We are talking about an antibiotic which is no longer able to work against either a bacteria, a virus that it was initially able to work to. And in the delivery of healthcare in Kenya, in as much as we aim to achieve the universal health coverage, is a challenge we are having because of various practices that we call drivers of antimicrobial resistance, ranging from practices by clinicians, patients themselves, like over-the-counter medication, being able to just buy drugs without a prescription. Veterinary practices, despite being health workers, sometimes you also own animals, going out there, buying an antibiotic and giving your animals. So all these are leading to situations whereby we are exposing our bacteria, our viruses, to traces of antimicrobials, and therefore they develop resistance. Then this resistance is then being transmitted between humans, animals, and especially through the environment. If resistance develops in livestock, and we take in products from livestock, then we risk developing that resistance. That way, we are really talking about what we call the One Health approach to managing antimicrobial resistance, a multi-sectoral collaboration between human health, animal health, and also the environmental actors. But critically for you, as the field estate, is about awareness. We have a strategic plan that focuses on addressing AMR, and one of the critical issues is public awareness on AMR. Alone, as a ministry or as the scientists, we may not be able to make sure this information reaches the public. So we plead that seek the information and deliver the right information about AMR to the public. So that's my major request.
So KEMRI and other organizations in Kenya and around the world are doing a lot of research to try to overcome the problem of antimicrobial resistance. One of the big problems is to know what is happening, what's the situation in our settings, in our hospitals, in our communities, in our agriculture, and that needs something called surveillance. Surveillance requires organization, it requires some materials, and it requires support from ministries, it requires support from hospitals, and it requires funding. So as researchers, we are undertaking surveillance and feeding data to the Ministry of Health, but we think that could be improved. We want to do it on a bigger scale. We want to make sure that the laboratories are running as best they can to be accurate and give reliable results to the ministry. And then at the same time, we can't just do surveillance, we have to do discovery. We have to find out what are the solutions to the problem. Do we have to use a different antibiotic? And efforts are underway to discover new types of antibiotics, but there may also be some already within our cupboards that can be used. And we take the data from surveillance to tell us whether we can use those antibiotics or not. And it'll be different in different situations. So if you go to a rural health centre, something might be very effective. But once you reach the intensive care unit, you're in an environment.
What we call 3 different levels of classification of resistance. There are those bacteria or pathogens that are resistant to just the common antibiotics. But then there are those that are also resistant to those that we would call maybe second level options. Where, for example, if level 1 doesn't work, you go to second tier antibiotics. And then there are those that are also resistant to reserved drugs that are reserved for very severe infections. And that's where we have now the danger zone of progressing to what we call XDR, extremely drug resistant, or even pan-resistant organisms, where literally that infection will not be treated by anything you have available here. And there you are left really to the mercies of... when we talk about antimicrobial resistance, it's not just for bacterial infections. Even antivirals in HIV have been resistant. We're talking about antibacterials, those that are resistant to bacterial infections, and even antifungals, those that can't work in some fungal infections. And there's a whole range of them. And in fact, I mentioned some common ailments like tuberculosis. There are drugs now that are resistant, but we keep inventing so that we have combinations that will work and try to delay. In bacterial infections, some of the common respiratory infections, Klebsiella pneumoniae and Streptococcus, species, different species of them that are resistant to antimicrobials that are commonly available for us. Typhoid fever as well. And we have seen recent evolution of even cholera itself becoming more resistant than previously thought. Some of the bacteria that cause bloodstream infections, very, very severe ones in healthcare-associated environments, Klebsiella, E. coli, and even Acinetobacter. Again, you find some of them almost 100.
Information. And we need your good words as the people of the Fifth Estate to spread this. The scientists will provide you with all the things you need. You will get all the information you need, but we have to tell the public about this problem. Somebody who doesn't know ABC gets some drugs from somewhere and inject into this animal, and that is the meat you will be eating everywhere, so it can cause a lot of problems. These antimicrobials can develop because of that. That's why we need the public health. We need to do the surveillance proper. We need to educate people proper. But as per prescription, please take the drugs according to the medicines, according to the way you are given. If you are told, you know, something like, for example, Panadol, okay, you are told it is 2x3. Panadol is one of the easiest things you can get anywhere over the counter, isn't it? But if you misuse it, you're going to get problems. It causes liver problems. It causes a lot of dangerous other diseases, problems to you, to your body organs. So there is no dawa which is 100% clean. No.